Hey folks, it's Dr. Gilchrist, and as promised, I am finishing up the last 20 slides from our lecture on opioids. So this is where we last left off. So we talked about the three major ways that opioids basically produce reinforcing effects. So first of all, what we do find is that the mesolimbic pathway, as we talked about last time, does play a role here. And generally what we're going to find is that the opioids will actually increase dopaminergic cell firing in the ventral tegmental area, leading to an increased release of dopamine in the nucleus accumbens. Now, this is obviously going to be a little bit different if you are stimulating kappa receptors, which what we typically find will lead to a reduced dopaminergic activity. So where we left off last time, you can see, for example, that certain opioids, so opioids in general, along with beta endorphins, ultimately inhibit inhibitory GABA cells. So they're basically going to inhibit something that's inhibitory, which leads to increased firing of this mesolimbic cell, along with a greater release of dopamine onto the nucleus accumbens. Now, compare that with something like dynorphin, which is also an opioid. Dynorphin actually works on kappa receptors right here at the dopaminergic neuron terminals between the ventral tegmental cells and the nucleus accumbens. And ultimately, you can see here that it works to actually inhibit dopamine release. So one of the things that we'll find, like with many other drugs that we talk about, is that repeated use will lead to tolerance and sensitization. And as a reminder, tolerance is defined as diminishing drug effects with repeated use. And what we are going to find is that not only can you develop a particular tolerance to a certain type of opioid, such as heroin, because opioids largely work on similar mechanisms, you are actually going to develop what's called a cross tolerance. So if you develop a tolerance to heroin and you have a really bad cough and you are prescribed cough syrup that contains codeine, you have developed a tolerance to any opioid. And so as a result, the codeine will not really do very much to alleviate your cough because you have developed a tolerance, and cross tolerance between opioids does develop. One of the things that we do find, in addition to developing tolerance, oftentimes with repeated use, we do occasionally experience sensitization. This is the increased effect of a drug with repeated use. Generally, what we are going to find is that sensitization, when we're talking about opioids, will most often occur for cravings. The more repeatedly that you take an opioid, the bigger that your craving becomes. It increases, even though the more that you take an opioid, the less often you will feel a high. And in some cases, with repeated use, you may not actually feel much of a high at all. So one of the things that I've mentioned repeatedly is that opioids have a really strong physical dependence. And what we find is that the neurons in your system basically change as a response to repeated use. So we get these neuroadaptive changes. And this will lead to physical dependence. What basically will happen is that if you are taking too many opioids, the receptors will basically downregulate. They will reduce their numbers. And what we'll find is that when the drug is no longer present, the cellular functions will return to normal, and they may even potentially overshoot. And what we will find is that these effects of these cell functions are often going to be the opposite of the effect of the drug itself, and these will be present in withdrawal symptoms. So withdrawal symptoms from opioids can actually vary based on many different factors, like the drug use, the dosage, how long you've been taking them. And depending on the type of drug, so morphine typically does not have very long-lasting effects, but methadone really does. Methadone has a longer half-life, and so it's going to stay in your system for longer. What we tend to find is that longer lasting drugs will have longer lasting symptoms, but oftentimes, especially with the withdrawal effects, they're going to be a lot more mild than something like morphine or heroin or Oxycontin. So as you can kind of see here, the symptoms of withdrawal are often going to be the opposite effects of the drug. So with analgesia, we get pain and irritability. With respiratory depression, we get panting, we get yawning. With euphoria, we get depression. With relaxation and sleep, we get insomnia. With producing calmness and a tranquil mood, we get anxiety. With decreased blood pressure, we get increased blood pressure, and on and on and on. And here's what I was kind of talking about with the withdrawal effects and the drug effects. So heroin has a pretty highly intense drug effect. This is partially due to its route of administration as well as properties of the drug itself. And so you can see that it's completely removed from the system after 8 hours. On the other hand, methadone is still present in the system within 32 hours. So when we look at the withdrawal effects for something like heroin, the withdrawal effects are short-lived, but they're pretty severe. They take place over a period of several days. On the other hand, the withdrawal effects that are associated with methadone take longer, but they tend to be a lot less severe as a result. So what sort of things can help eliminate withdrawal symptoms? In the case of coming off of opioids like heroin or Oxycontin, in many cases, withdrawal can be fatal. Do not try to withdraw from opioids cold turkey. What you need to do is detoxification. So oftentimes we're going to do detoxification with other types of low-grade opioids, things like methadone or buprenorphine. And detoxification is basically the point when withdrawal symptoms end. Generally, we're going to find if the opioid is re-administered before that point, the symptoms will be eliminated, but this will also happen with other opioids. However, low-grade opioids like methadone or buprenorphine can also actually stop and reduce the symptoms. Now, one thing that I will mention is that even if you are not addicted to an opioid, you can actually still develop a physical dependence. And this is something that we see with patients who are taking opioids to manage chronic pain. They show signs of tolerance and physical dependence, even though they are not technically qualified to have a substance use disorder. Now, if you know somebody who is dealing with chronic pain and they need opioids to manage their symptoms, you have to pay careful attention to the dosage, and ideally you should be trying to reduce that dosage over time. And when you do that, when you think of an end game in mind and you start reducing the dosage to manage the symptoms and also reduce withdrawal, we do find that withdrawal symptoms are less likely to happen, as is drug abuse. So what parts of the brain are involved in withdrawal? And here's what we know. When we apply an opioid antagonist to the brains of opioid-dependent animals, we find that the locus coeruleus, which is where norepinephrine is produced, as well as the periaqueductal gray, are very sensitive to the antagonist. And this actually kind of makes sense because a lot of the withdrawal effects that we get from drugs are often due to the actions of the autonomic nervous system, both the sympathetic and the parasympathetic nervous system. For opioid withdrawal, it probably means that the sympathetic nervous system is going to be a lot more involved in those withdrawal symptoms than the parasympathetic. The nucleus accumbens also seems to be important for aversive effects and the motivational aspects of withdrawal. So one thing that we know about animals is that they tend to prefer novelty. As I mentioned in class yesterday, animals generally don't like to return to the same place. They don't necessarily want to look at the same thing. They prefer novelty. If you apply an opioid antagonist to an opioid-dependent animal, we actually find that they develop a novelty aversion. They are not interested in trying new things, and so this may suggest that the nucleus accumbens not only plays a role in the reinforcing effects of a drug, but it also plays a role in the withdrawal effects that are experienced. So something that is kind of similar to the opponent process theory that we talked about before when we talked about different models of drug addiction is a theory that was developed by Himmelsbach. And he specifically developed this theory with respect to opioids and withdrawal and drug tolerance. So the goal of your body at any given point is homeostasis. Your goal is to be in balance. You don't want to be too hot. You don't want to be too cold. You don't want to be too hungry. You don't want to be too full. You don't want to be too thirsty. You don't want to be completely overlogged with water. So the goal is balance. So if I take something like an opioid, that introduces a disturbance into my system and knocks my body out of balance. So the nervous system, while you're taking this drug, you are constantly introducing a disturbance. Your brain, to help maintain that homeostasis, is going to start engaging in compensatory mechanisms to help counteract the effects of the drug and actually put you in a sense of homeostasis. So here we take the drug, we have some compensatory mechanisms that produces homeostasis. Now, over a period of time, those compensatory mechanisms may potentially lead to effects of tolerance. So we are going to feel less of the effects of the drug because the goal of our body is to be in homeostasis. At some point, if I remove the drug, one thing that I will mention is that these compensatory mechanisms, much like opponent processes, are slow to adapt and they're slow to modify themselves. So if I stop taking a drug, I remove that disturbance from my body completely and quickly. But the compensatory mechanisms are slower to adapt and they are still in play. So as a result, we see that this adaptation will continue and we get this rebound effect where we actually, once again, temporarily have a disturbed homeostasis. So with the withdrawal effects are basically all of the compensatory mechanisms that your body's been trying to engage in to counteract the disturbance of chronic drug taking. So here's some evidence for Himmelsbach's theory. So one thing that we know is that opioids, like morphine, actually inhibit a substance called adenyl cyclase. This makes cyclic AMP. Now, here's what's interesting. So here we have an animal and we begin a morphine treatment. So what you're looking at here is the percentage of normal cyclic AMP. So because morphine has this inhibitory effect, once I introduce morphine, you can kind of see that we temporarily get a loss of cyclic AMP due to the inhibition of adenyl cyclase. So we get this loss, but over time, notice that we get back to that normal state. And that's because our body is engaged in these compensatory mechanisms while we're taking the drug. So again, we see that homeostasis. When we withdraw morphine, you can actually see a significant rise in cyclic AMP because all of the compensatory mechanisms are still in play. So we're going to get a very brief rebound effect during withdrawal, potentially contributing to withdrawal symptoms before returning to normal and achieving that homeostasis. Classical conditioning and operant conditioning can also play a role here. What we know is that if you repeatedly give an animal an opioid in a particular environment and you put that animal in the environment again, they start engaging in anticipatory physiological effects. They are preparing for the likelihood of receiving that drug. The environment has become a conditioned stimulus for the drug effects. We also know that in humans, your tolerance actually lowers in a novel environment. So the effects of tolerance actually change when you're in a new place. And one of the things that we do find is that a lot of people who take a drug that they take a lot in a certain environment and then they take it in a new place, they actually run the risk of overdosing because they don't have that conditioning to help with those compensatory mechanisms. Additionally, we do find that environmental factors that are associated with drug taking become secondary reinforcement. They become conditioned reinforcers, and that can include injection rituals, different social groups, or environments where you tend to take drugs. So what you're looking at here, obviously this has to do with cocaine. This does not have to do with opioids, but what you're looking at here are cocaine users, and they are either watching a nature video or they are watching a video that has to do with cocaine. And what we find is that when you show them the cocaine video, you get increased activation here in the amygdala as well as the anterior cingulate cortex right here. Both of those, and this is kind of related to emotional memories as well as expectations that those drugs are going to arrive. We start to see the rise in craving. Both of these areas have connections to the nucleus accumbens and these drug cues. So looking at a picture of somebody basically chopping up cocaine with a razor actually acts as a primer for craving. It basically helps cue you to basically start engaging in craving and drug-seeking behavior. So now let's finish up by talking about treatment. So again, addiction is a biopsychosocial problem. We have biological factors, cultural factors, and then we have psychological factors. So chronic drug use and addiction is often going to be a multi-factored problem. So good treatments need to not only consider the physiological, they also need to consider one's psychological state as well as different environmental factors. So, like alcohol abuse, with drugs that have a strong physical dependence and dangerous withdrawal symptoms, detoxing is the first step. So generally, detoxification is usually going to involve a long-acting opioid like methadone or LAAM to basically reduce those withdrawal symptoms. And generally what we're going to do is decrease that dosage gradually over a few days and reduce the withdrawal symptoms to a level that can be managed. Now, clonidine is another possibility. So for those who don't know, clonidine is often given kind of as an anti-anxiety drug sometimes, and it works on norepinephrine. So it's basically an agonist of it's basically an agonist to these particular autoreceptors. Now, we haven't really talked much about autoreceptors in class. Autoreceptors basically will pay attention to how much of a neurotransmitter is being released, and autoreceptors can actually cut the amount of neurotransmitter that's being produced and released by a cell if too much is being released. So clonidine actually reduces norepinephrine in the locus coeruleus. And what we find is that oftentimes you would want to reduce norepinephrine here because norepinephrine typically gets inhibited by opioids, and during withdrawal, norepinephrine releases at a very high rate, activating the sympathetic nervous system and causing a lot of scary withdrawal effects. So if we can reduce norepinephrine by working on these autoreceptors and cutting norepinephrine, we can reduce the severity of the withdrawal effects. Now, one of the problems is that clonidine doesn't relieve all of the symptoms of withdrawal, and it has its own side effects. So usually something like methadone is going to be preferred. So methadone is actually a pretty common treatment for addiction. A very common treatment is what is known as a methadone maintenance program. It is a long-term substitution of methadone for things like heroin or Oxycontin. Now, the idea behind this is that because methadone is a longer-acting opioid, it doesn't really produce a very big high. And it doesn't really have a lot of bad withdrawal symptoms. So the idea is that it's going to relieve your craving because you're taking an opioid. It's going to reduce the drug-seeking behavior, and it actually frees up energy for more productive activities. And what we find is because this is an opioid, you have a cross tolerance with the opioid that you're abusing, and you have a cross tolerance with methadone. And so because of this cross tolerance, you're probably not really going to get high off of methadone, and it actually reduces the likelihood of a relapse. Now, methadone actually does have an abusive potential. If the pill is crushed because it's taken orally, if it's crushed, and then liquefied and put in a syringe, it can actually get you high if you inject it through IV. So for this reason, methadone maintenance is often regulated. So you have daily supervised oral administration. You go to a methadone clinic, they give you a pill, they watch you take that pill, and then you leave. So there's very little euphoria that the methadone produces, but it does reduce the cravings, and it also reduces using needles. It reduces the ritual of injection and the risk of disease that happens as a result. Now, buprenorphine is another maintenance method. It's sold under the name Buprenex. It is a partial agonist of opioids with weaker effects, but it has a longer duration than methadone. So you would want to take doses only a few times a week. As we talked about before, if we combine buprenorphine with naloxone, which is an antagonist, it is available as Suboxone. So here's why you would want to sell this as Suboxone. Similar to methadone, if you crush and inject buprenorphine, you can get high. It is an opioid. But if we combine buprenorphine with naloxone, naloxone will basically block the high if somebody decides to crush Suboxone and inject it. But there's still a potential for abuse with these drugs. Now, other types of treatments out there will use narcotic antagonists. One is naltrexone or Trexan. This has a longer duration of action than naloxone. It is also taken orally with few side effects. We have nalmefene or Revex. This is pretty similar to naltrexone. It's more potent, it's longer lasting, but these drugs don't really eliminate craving. But again, these are all biological approaches. We want some psychological and environmental approaches as well. So oftentimes there will be a combination of detoxification, pharmacological support through medication, and counseling. And generally, good counseling is going to help you identify those environmental cues that induce craving or induce you wanting to take those drugs. And so you are also trained with counseling to develop a good behavioral response to those cues. Narcotics Anonymous is going to be another option for you as well. Those group meetings can be really beneficial. So that's pretty much it. Let me know if you have any questions, and I will see you tonight at the Zoom session. Bye.